Hello, everybody. Welcome. This is our Ask Me Anything on the future of digital mental health. My name is Jennifer Greenberg. I'm one of the co-chairs of the conference, and I'm extremely excited to be the moderator for this AMA. We have three distinguished speakers. I'll start by introducing each of them briefly, and then I'll turn it to them for so they can each orient us to their experience and their thoughts on this topic. And then really the intention of AMAs is to make it a conversation and make sure that your questions are being answered. So as such, please unmute yourself and ask any questions. Is anybody hearing another?
I work in academia, but I also had some really rewarding industry collaborations, and that's why I'm very excited.
Okay, did that fix it? Okay, wonderful. Sorry about that.
Or at least the ones that are potentially relevant for the current panel.
So I think anyone who's unmuted, make sure that you don't have the lobby, the live stream from the lobby sound on. Otherwise, we'll get competing presentations. But as I was mentioning, this is really intended to be very interactive. The intention is for the audience to get to ask questions of these three distinguished speakers. I'm sure we can answer everything about the future of DMH in the next 50 minutes. And I will, unmute yourself, but I will also be watching the chat and the Q&A. So if you want to pop your questions in there, feel free and I can moderate them. But I'd love to just get started with introducing our speakers. Our first speaker is Patricia Arean, who's the director for NIMH's Division of Services and Interventions Research and is a clinical psychologist. Dr. Arean is a leading behavioral scientist with an expertise in cross-cultural mental health, social determinants of mental health, geriatric psychology, assessment and treatment of depression and anxiety, the use of human-centered design for adapting psychosocial interventions, and the use of technology to conduct surveys, user experience research, and clinical trials to scale. Prior to joining NIMH in August of 2023, Dr. Arean was the director of the NIMH-funded Alacrity Center, the Creative and MHATS Digital Laboratories at the University of Washington. Dr. Arean has published on the recognition and treatment of depression and anxiety, methods for recruiting and retaining large and representative numbers of adults into longitudinal research, and acceptability of using digital methods for the purpose of screening and treating mental illnesses. Our next speaker is David Mohr, who is professor of preventative medicine and chief of behavioral medicine in Northwestern University's Feinberg School of Medicine, with appointments in the departments of psychiatry and medical social sciences. Dr. Mohr is director of the Center for Behavioral Intervention Technologies, CBITS, and leads the multidisciplinary postdoctoral fellowship in digital mental health. Dr. Mohr's research lies at the intersection of behavioral science, technology, and clinical research, focusing on the design, evaluation, and implementation of digital mental health technologies and services. Dr. Mohr is a fellow of several organizations, including the American Psychological Association, and is president of the Society for Digital Mental Health. His research has been continuously funded for more than 30 years by the NIH, other federal agencies, and numerous foundations, resulting in over 300 peer-reviewed publications and more than 25 book chapters. And last but not least, Dr. Katrina Roundfield, who is a licensed clinical community psychologist who transitioned her career from academia to entrepreneurship. Throughout her career, she has maintained a focus on designing, implementing, and evaluating innovative mental health services within community and digitally based settings. Currently, Dr. Roundfield is a co-founder and chief clinical officer at Appa Health, an app-based adolescent mentoring and mental health skills company. At Appa, she leads science and operations and serves as the principal investigator of a $2 million SBIR grant funded by the NIMH. Prior to co-founding Appa, Dr. Roundfield led clinical operations as a founding team member at 2 Chairs, growing the company from 0 to hundreds of therapists, serving thousands of clients monthly. She currently maintains an advisory position at 2 Chairs. Dr. Roundfield completed her master's and PhD in clinical community psychology at DePaul University, her residency at Yale University School of Medicine in the Department of Psychiatry. She completed a postdoc fellowship at the University of California, San Francisco School of Medicine, where she maintained an affiliate faculty position until 2022. Dr. Roundfield is a task force member of the California Reducing Disparities Project to advance mental health equity, and she's a National Academy of Science Ford Foundation Fellow. Thank you so much for joining us, Pat, David, and Katrina. And I'm now going to turn it over to you. If there's anything you'd like to add about your experiences and your thoughts on the future of digital mental health before we open it up to the audience for questions. Why don't we start with you, Dr. Arean?
Sure. I'm not going to add anything to my experience. I think that was well summarized, about good 35 years of work in the field. So just to kind of clarify, my role as the Division Director for Services and Interventions Research means that I focus on the implementation side of clinical trials research. Although we do fund studies on the efficacy of novel interventions, a big bulk of our portfolio is around the effectiveness, reach, implementation, and service design of strategies to increase access to evidence-based treatments. And I would say that there's a number of things in digital mental health that we already fund that will be the future theoretically in the next 3 to 5 years. So for instance, we fund a number of things in looking at the optimal dose of digital mental health. So better understanding what does it mean to have access to digital mental health? What's the optimal dose? How does that track with traditional treatments? So we better understand the use patterns that we see when people are downloading apps for mental health purposes. We also fund research looking at supporting the workforce in the delivery of evidence-based practices. So how technology and digital health can be integrated into the health system, into electronic health records, so as to support decision-making on the clinician side and also support adherence and management of treatment on the consumer side. We also focus on looking at the impact of digital mental health on older adults. We're interested in its use in rural areas, given the limitations that a lot of people who are living in rural and frontier areas face with regards to access to broadband. We're also interested in the impact of digital technology on youth mental health, both positive and negative, and how that can be leveraged for improving the mental health and well-being of younger people, which I think Katrina will probably be speaking to a little bit about. Other things that we're looking at and that are not stated priorities yet, but one thing I've been interested in seeing is how we can use technologies to address social determinants of health in combination with delivery of evidence-based practices. In particular, we're waiting for the Supreme Court to weigh in on, what counties can do with regards to homelessness or homeless people and living in the streets and all of that. I sort of have this vision of it would be really cool to see something like, and this is kind of a crude description, but like an Expedia for services, where somebody could have access to just like a tool that would say, this is where you can get some food. This is where these are the these are the housing units that have space available for families, for individuals, and so forth. So some kind of clever way to help people manage their basic needs so that they can also manage their mental health. And finally, we're also interested in what role technology or digital mental health can play in the service system. We're exploring models for sequencing or combining interventions, looking at stepped care approaches to manage and make the mental health system more efficient. These are also ideas that we're interested in seeing. So I'll stop there. And I guess, do you want me to do popcorn? I can turn over to Katrina.
Thanks, Pat, and thank you, Jennifer, for that introduction. I'm really happy to be here. I think a few thoughts that I'll mention, and I'll speak from the perspective of, I'm a researcher and have many thoughts on sort of digital mental health, but I'll try to focus this particular section just on giving folks a bit more context about Appa Health, which is the company that I am a co-founder of. So, some of the points that Pat actually just raised are some aspects of what we are doing here at Appa. One of the things that is particularly interesting is just the implementation of services and sort of thinking about how can we leverage technology to make the implementation of mental health services better and more accessible, more equitable. So what we do over at Appa Health, we, as you mentioned in the introduction, we're a teen-based mental health company. Our mission is to provide accessible and equitable services to young people through the delivery of world-class mentorship. And we think that world-class mentorship is best through near peer-based models. So really thinking about the workforce and thinking about who can provide that type of support to young people. Really thinking about what the scope of work is for a near peer mentor is really important to us, and really making sure that that work is scoped down enough so that it is not coaching, it is not therapy light. It is truly mentorship, and mentorship actually in a lot of the communities that we serve, we actually sell into public school districts right now. In those public school districts, we find that mentorship is a really meaningful word that does not have the same kind of stigma that saying a mental health professional is helping your teenager. We contact families and tell them that we are providing mentorship, and that is really well received. We have a 75% uptake from parents when we call them on the phone and tell them that we are offering mentorship to their teenager. So that's, part of the equitable and accessible point is just kind of thinking about how do we sort of leverage technology to connect young people to mentors in their all across the country. Actually, our mentors are all across the country because technology allows us to connect them to folks anywhere. And then the other component is really thinking about, as we know, young people are on social media all the time. In fact, we were just hearing, I think today, there was a article in the New York Times talking about how the Surgeon General is suggesting that there be warning labels on social media platforms. We'll see how that all turns out. But, one thing we know is that I think in 2021, the most hashtagged hashtag was hashtag mental health, because on TikTok, on various sites, young people are talking about mental health, but a lot of the information, some of the information that is proliferated is not evidence-based, is maybe even harmful, is not fact-based. And so what does that tell us about user behavior? It tells us that teenagers want to learn about their mental health. It tells us that teenagers are seeking this information, but the quality of that information is variable. And so what we are doing on our platform is actually creating content that is mimicking the styles of TikTok and styles of those kind of influencers, but we're doing it in a way that is evidence-based. We write all the content. We put that through our clinical advisory board. We make sure that it's evidence-based, but we do make it 30, 60, 90 seconds. We do make it short. We do make it pithy. We make it engaging. We actually contract with actual influencers who are themselves licensed therapists. We write the content for them. And then we deliver that all in a package to young people so that they are not only getting that one-on-one mentorship, but they're also getting an evidence-based course of care with the mentorship, so that the mentorship is not just kind of unscaffolded. So that's a little bit about, I could say more about the bigger picture of the future that I personally see for mental health. But with that, I'll pass it over to David.
Thank you. So I first of all, I just want to say, this is in the audience here, there are lots and lots of people that know a huge amount. And so as we start discussing, I hope that people join in. The three of us, I think, have some perspectives on the future, but nobody really, nobody has a lock on it or knows where it's going. So I hope you all, join in with your thoughts. I'll just say a few words in, kind of my role in the Society for Digital Mental Health. So the origins of this society actually came from a consensus document that came out that Pat, Arean, and I co-authored. That was the result of a multi-stakeholder group that included payers and healthcare systems and companies and lots of other stakeholders, looking at what the challenges were in the rollout of digital mental health. And the two big blockers or problems were the absence of a clear regulatory system and the absence of payment models. And that this was, this meeting occurred, or the meetings occurred pre-COVID. The document came out in 2020, and you know, not much substantive has changed since then. So part of, you know, what we're doing in the society is seeing where we can work with other organizations to try to promote, you know, meaningful and reasonable regulation, as well as the development of payment models, which we have to have in our system, because we are still, even though we've been trying to move towards a value-based care system for decades, we still, most of the, you know, most of our healthcare system is still fee for service. But I don't know that that alone is going to solve all of our problems. So when we look at, you know, Europe or, you know, Australia or other countries that have, you know, have some forms of regulatory system, regulatory processes in place, or have, you know, some payment models in place, you know, they're still struggling. So, you know, the UK has integrated into what used to be called IAPT and is now called talking therapies. Ireland rolled out digital mental health nationally a couple of years ago. Sweden has been doing this for a long time, as has Australia. And when you look at kind of the uptake, it's pretty low. You know, it's, you know, usually somewhere around 0.5%, 1% of what you might expect to be the population of people with mental health problems that could benefit. So even there, even though, you know, there are methods for payment, there are systems, the uptake is really low. So, you know, I think a big challenge is going to be, you know, how, you know, what are the processes, what works for integrating these kinds of tools into healthcare systems, into schools, as Katrina is doing, into, you know, into other places where people with mental health difficulties are, and where the organizations have some vested interest in taking care, you know, taking care of them. So, you know, those approaches, even in countries where, you know, where they're further ahead on the regulatory and payment issues, they're still confronting those problems. So there's a lot of work to do. But I do, you know, I do have a lot of optimism, because what we see is, you know, in these countries where they are rolling it out, it's steadily increasing. They are figuring out how to do this, but it's not easy. There are many steps on this path, and we are still in the early days. So I'll stop there.
Thank you all so much. I'm going to open it up to the audience. Feel free to unmute yourself. You can also put questions in the Q&A or the chat. And I'm actually happy. I don't see anybody yet, so I'll take this as an opportunity to jump in. I wanted to piggyback, David, off of what you were just talking about, where, you know, we have a lot of questions about and hopes for regulatory pathways and reimbursement. And yet, when you, as you mentioned, when you look at countries, even where those issues are being addressed, it's not sufficient, and the uptake is still low. So what do you view as sort of the real missing piece and a real opportunity for future growth and future better integration into the healthcare systems and schools? And I'll open it up to you first, but I'd also be curious to hear also Pat and Katrina, your thoughts.
Yeah, I'll certainly leave the schools part to Katrina. You know, with the healthcare systems, I think, as we heard today from Trina and Sue and Faye, it's a real challenge, but it is doable. There are, I think that, you know, we have to recognize that it's, you know, a healthcare system isn't one entity. It is a collection of lots of different entities within that, all of which have their own interests and their own objectives. And so, you know, you're trying to line up those objectives and getting everybody on board and kind of pointed in the right direction. And often it's, you know, in the process of that implementation, you're making a lot of sacrifices and trying to figure out, because when you're starting out to implement, you can't do everything, and you can't you know, meet everybody's goals. So you're trying to decide, you know, we have to move this into an EHR, but that's expensive and it takes time. So what are ways that we can kind of get around, you know, what are ways that we can kind of get around that just to kind of start to demonstrate the value of this to the healthcare system. So I think that there's, there are a lot of efforts underway, and I think that's part of what this work group is doing is trying to surface that. The other thing I'll just say before turning it over to the other folks is I really like this idea that you had, Pat. I hadn't heard about it before, having kind of an Expedia kind of thing for for services, and it sort of reminds me of the efforts now that the American Psychological Association has started to undertake around population mental health, and how we can begin to approach population level services that may not necessarily also fit into a fee for service system. So insurance is better, but it's we have a very messy system. So it's not like countries that have kind of national healthcare systems where everybody's insured, and once they get that in there, people will presumably have some form of access. But developing methods for population mental health, I think, will be have to be part of the American solution that may be somewhat different than other countries. So I'll turn it. Yeah, go ahead.
I mean, I don't want to take Chris. Chris has got his hand up, but I'll just say that the other thing to consider is that it's not just the healthcare system, but all the all of the inputs into it. So training is a big deal. Credentialing. We had experiences with the collaborative care codes where, collaborative care is an evidence-based service model to increase access to mental health services and primary care medicine. And a lot of effort went into creating billing codes through CMS. And what do you think happened? Nobody used them because they didn't know how. And there was still a lot of confusion over, because a lot of what the codes were supposed to address were first having a care manager in the system, which was not something that was normally supported in primary care medicine, but also the ability to bill for services on the same day in one clinic or in one office, and which was not something you could historically do. And that one barrier, it involved a lot of education to the clinics that you can actually bill twice for like the same patient in this service. That's allowable under these codes. So there isn't a lot of dissemination about how to use billing practices. I think the other point, and then clinicians don't know how to use these tools. It's not something that I'm aware of that is being taught in graduate training programs. It's not addressed in licensure or credentialing training. And then there's the patient, kind of not sure, well, what's helpful to me, or how is this going to be helpful to me? And so I think there's a lot of education and a lot of support that has to happen around making these tools available to people. I'll stop there.
And I'll just mention one very quick point on the school perspective. I think that one complexity of working in school systems, at least in the US, is that many young people, the question of who pays is a question. And so I think if you are a pure kind of healthcare play, that oftentimes looks like going through health plans, but it also means you really need to get all of those health plans aligned. And in a school system, because we don't have a single payer system, that means you need to get multiple payers onto your platform and bought into your reimbursement and all of that. And I think that presents like quite a bit of complexity and a barrier to distributing these types of services. And one thing that we have sort of been fortunate to go around, because we are sort of a healthcare adjacent model, because we're mentorship, it's mentorship. It has a lot of benefits to mental health, but it also supports kids in a number of other ways. And so this healthcare adjacent model allows us to go directly to school systems as a payer and kind of go around this issue of having to have different health plans sign on to deliver these services to the students.
Thank you. These are extremely important points. Very interesting. And Chris Hazen.
Sure. Thank you. So thank you to the speakers for being here and for the work that you're doing year in and year out in this area. It's amazing. It's such a sort of combination of frustration and excitement working in this area. I'm sure you experienced that a lot longer than I have. The question I put in the chat also is what are you seeing in terms of digital tools, or are there other approaches that are working that support therapist training and fidelity management in actual practice. So to the points just raised, I mean, I've been trying to disseminate a evidence-based digital mental health treatment for families over the last 3 years, and so many people at the administrative level get excited about using this kind of technology, and then it gets to the working level, and they're just like, "Are you kidding me? You don't think we're sick of technology yet? Are you not hearing us?" I mean, this kind of like, just outrage almost that somebody decided that a digital mental health technology might actually be a better, faster, cheaper to reach a lot more people and get them a lot more care. So there's that approach to training and fidelity management that actually works with use of digital tools is a really big question. I'm just interested if you're seeing success stories out there that we could all learn from, or standards being developed, or yeah.
One of the audience members just emailed me about an example from our SBIR called 988, which increases fidelity. Adam, do you want to say more about that if you're on the line? Since you sent me the email.
Yeah. Hi, this is Adam Haim. I'm not going to dare show my face. But so we funded Dave Atkins from Listen. And the goal here really was to use technology, digital health technology, to embed into the 988 call taker systems, and there's a number of them across the country, to try to look at derivations in the implementation of the embedded 988 intervention, and optimize that in real time, both at the individual level. So at the individual level who's taking the call, the care provider, as well as at the administrative level, to identify opportunities at that level to change the implementation of that intervention. And so it's been supported by SAMHSA, and we're really enthusiastic about that. And I think it provides a really nice example of increasing the fidelity and quality of interventions.
I'll add to that Dave Atkins tool, I hadn't seen it in a while, and I just saw it at Beckfest on Friday, and it is really impressive. I mean, the feedback it gives the clinicians is really easy to access. The interface is really highly usable. And so I think that's the other thing too, is that as opposed to other training tools that have been out there that use avatars and all of that, this is like a really beautiful, straightforward way to get people to, and it gives you positive feedback too. So somebody gave the example of a therapist who was really high on, interpersonal skill and all of that, but kind of low on fidelity, and having that mix of information, like you nailed it with the nice fuzzies, the better terms than that, but you could use a little work on, making sure you talk about action plans or that kind of thing. So it's, I think the interface for these things is highly important. And I believe that Dave's team or Listen organizations really work closely with, representative therapists to enhance its usability.
Yeah, I'll take a slightly more negative. I apologize, and I do think that what Dave Atkins is doing is amazing, and the work is fabulous, and putting it in a place like 988 makes a lot of sense. When we've done this work group getting feedback on implementations, one of the biggest problems in implementations, or one of the big pain points, is mental health people. It's really hard to get mental health people to change their ideas about how mental health treatment should be provided, what their roles are. I mean, just think for a moment about measurement-based care, right? The idea, very simple idea, right? You just measure at various time points, the symptom severity or so on of a patient, and at designated points every 4 weeks or whatever, there's a discussion with the patient about how they're doing and whether they should change the treatment plan, right? This is done in every other area of medicine. You would never do, treatment for diabetes or hypertension or something else without measuring outcomes. Only in mental health do we not do that. And it's been recommended in almost every, major country as part of care, and it has not been rolled out. And one of the places that you get resistance is, from mental health, because, a lot of us, we have, privacy. We don't want anybody to know what we're doing. We have our magic. We don't. So I think that I think that that's a place where we need to work to overcome some of these challenges. And some of that's going to be in training, where, the next generation is going to be trained. And some of that, I think, also means, figuring out how to make these tools useful to clinicians. So we think giving people advice is helpful, right? But their perception is that it's telling them what to do, that it's controlling. So, if you start building these things, any clinician adopts things that are going to be helpful to them. So figuring out, is it, do you build into the system things that can help with scheduling or with billing or with something else that takes a load off of them, so that there's an incentive for mental health providers to use these things. I think we have to, again, look at also do our human-centered design with the clinicians to understand how to embed these things in their daily lives in a way that's going to make, help them with a problem that they have.
I think that is so important, the multi-stakeholder approach, and really thinking about, and from the ground up, working with people and thinking about what's going to help them, what's going to get their buy-in, and potential barriers. I wanted to also highlight some questions that have come in through the chat and the Q&A. I'll start with two similar questions in the chat, are asking really about how are we ensuring equitable systems when we're building things? Are mental health apps or AI ever going to be free? We think about health disparities and barriers to care and access, and we talk about these in our trials, but the question is asking about, when we get our products out there and in between insurance and the fees, are they actually going to be accessible to diverse individuals, or are there going to just be additional barriers to accessing the products that people, again, from this user-centered design, help to create? How will they actually access it in the end? And I know, Katrina, you've been doing a lot of work around that. Do you want to?
Yeah, I'd be happy to chime in. So one thing that, even as we began to develop Appa, I think, many of us came in on the founding team with our own sort of perspective on what are the major barriers to access. And I think, yes, cost is one, but I think David made a great point around, even when you have these or models that can be reimbursed and models that are accepted by insurance and payers, there still is quite low uptake. And I think we at Appa, came with that perspective because, the genesis of the company was associated with a few different lived experiences on the founding team. One being my co-founder, who had a son who had a mental health concern, and his son actually, had all the resources to go to therapy, but his issue with the accessibility wasn't the cost and wasn't whether he could find a therapist. It was actually, it wasn't engaging for his son. His son didn't find the product to be, like therapy itself, the service, to be a fit for what he wanted and what he was, really looking for. And so, and then I came from the perspective of, as a child and adolescent psychologist, I remember, child and adolescent psychology 101 is, kids don't want to go to the therapist. The parents often make them, they come kicking and screaming to your office, and you have to work double time to, build rapport. And I just oftentimes wondered, why is that? And that's even more pronounced among communities of color. That's more pronounced among LGBTQ plus communities in terms of, the acceptability of the service. And so I think with that in mind, we developed Appa, where we thought more about, why do people not, young people not want to go to these services? Why is it that they are not engaged? Also, why is it that there's a 1% uptake of some of these digital mental health interventions, and that 90% of people will drop out of those interventions within the first couple of weeks of the self-service intervention. So we did think that the human component was helpful in our model, something that actually kept kids accountable and kept them coming back for more, but also the who is the person who is actually going to be delivering that care. And then I think at a very bigger level, what we had to figure out was the distribution of that service. So what we ended up figuring out in school systems was, if you partner with the school system, some of these systems are not trustworthy to families. Some of these systems are not systems that they feel like they have had positive experiences with. And so one thing that we took into our own hands was actually doing the outreach and not having the schools do the outreach. We outreach to families. We have like a very specific way of outreaching to families. We speak in their language. And in fact, I'll just share one anecdote that we spoke, our team speaks Spanish. We spoke to a family who speaks Spanish, and they explained to our navigators, wow, no one from the school has ever called me and spoke Spanish. No one has ever called me and spoke Spanish. I get emails all the time. I don't even know what they're saying because I don't speak the language. And so I think really thinking more about how we're distributing these services and how we are engaging our consumers from the very outset is really important. And we at Appa had that hypothesis from the beginning and sort of built it in that way.
Thanks. That makes so much sense. Again, thinking about barriers beyond just costs and really speaking to people quite literally in the language that they need things, but that also means, reading the room that a lot of people are, the stigma around mental health, that you may need to be more creative in terms of how you're actually offering services. There are a few questions that have come in asking about privacy. Obviously this is a major concern with digital tech and mental health. What are your thoughts on how can we build trust and engage users with these technologies and methods that they might consider intrusive? David, do you have any thoughts on that?
Yeah, I mean, it's certainly, when integrating with healthcare systems, it's a huge part of the conversation. How data are managed, how they're, obviously they have to, systems have to be HIPAA compliant, how data are transferred in. I think they're also, you have to understand from the user base what kind of data they want shared, what is okay. And I think, ultimately giving people some control over the data that is transferred or into a healthcare system, and healthcare system writ large, not just hospitals and clinics, but wherever health or mental health care might be provided. We've seen when we've done some surveys more around sensor-based data, so data that can sometimes be much more sensitive. And we have seen that people are willing to have their data shared, but usually it's in contexts that make it understandable. So they don't want all data moving. They understand, like, mood scores or something like that might go to their clinicians, so that they, because they understand, implicitly they understand that might help, but they don't want necessarily geo-tracking going into their healthcare system. So I think it also, it's not just sort of generally what kind of data need to be completely private and what kind of data might be open to certain people, but it's understanding kind of who the recipient of the data is, why they need that. So those are a few thoughts.
Yeah, and along the same lines, there was a follow-up to that question of, like, how are clinicians and consumers, how can they figure out which products are ethical, protecting their information? How is that, the data transparency?
Yeah, that is a problem. There should be privacy, some privacy documents that are available, but at least, I know John Toros has looked at this and seen that, what the companies are doing and what they say they're doing don't always line up. In fact, more often than you would want to see, there's a discrepancy there in how companies are using. So I think that there does need to be some way of managing that, and possibly that's some part of a regulatory system eventually.
I see there's also a question around funding priorities. Is the priority with regard to funding to create new technologies, or given the plethora of existing digital mental health interventions, is it really more, the question asked specifically about NIH, looking for more partnership grants with existing technologies? So I can turn that maybe to Pat.
I would say both. We're really interested in innovative technologies. Some of that work happens in my sister division at Translational Research, but some of it happens in our SBIR program and also in our division. So novel interventions are always of great interest to NIMH. We also have mechanisms to support partnerships between industry and academics to work together to study the impact of their interventions. I think the SBIR is also another really good example of that. We also have a PAR on digital laboratories, where the intention really is to have academic researchers working with industry partners to understand things like optimal engagement, or what the impact of their intervention really is in the broader world, like effectiveness questions like who's being missed, who's responding, who's not, and understanding what those variables are that's driving things like voltage drop that we see often from the laboratory studies and to the world, where the effectiveness of the intervention looks super promising, and then you put it out there and it's gone. So any of those studies would be of interest to us, and we have a number of announcements that would fall into that area.
I also see a question that came in on clinical training. So going back, David, to a comment that you had made about mental health clinicians who may be resistant to change, and training may be a way to help reduce resistance. And the question is, what are some of the current ideas around viewing graduate programs or universities who train clinicians as the consumer of products, or the target customer? And I also want to actually, on that note, highlight that tomorrow we have a student SIG event at 5:10, which is specifically a presentation on digital mental health training needs. But maybe I can turn that over, since it was touching on something you had said, David. Do you want to take that?
I can start. I'm sure maybe my other co-presenters have ideas, but I'll back up and say a few things. I mean, I've noticed, certainly there are more and more students who are interested in going into industry. As a clinical psychologist, up until a few years ago, we pretty much had two choices. You either, go become a clinician, or you become a researcher, or you try to do both. But now there's this new direction, and we have fellows who are going into industry. We've seen people like, we've had people from our center, leave academics. I hope not because they didn't like us, but they saw, more opportunities to be able to make a difference in the world in industry. And so, I think that there is a move towards people at higher levels of training moving into industry. Psychology training programs are probably about as resistant to change as trained clinicians are. So I think it's going to take some time, but I think in some ways the students are going to be some of the drivers of that, because students have, training programs have to respond to the needs and the wishes of the students. So one of the things that we're doing in the society to try to address that is we've been talking to industry. One of the things that they're looking at is, they need to build a workforce, and they need, that industry needs qualified people. And so they have internship programs. So we're looking at trying to work with industry and with training programs to build sort of an infrastructure for kind of a clearinghouse to help students get internships in industry. But at the same time, a student going off and working for a summer in a company might be kind of difficult. It's done a lot in engineering and computer science. This is sort of standard part of training. People go off to Microsoft Research, but a lot of these companies, it's going to be one or two people. So we're looking at what kind of programming can we as a society provide you know, for interns who are spending time in industry so that they have a richer experience. It's not completely fleshed out, but it is one of the ways that we're looking at how we can begin to push, at least start some baby steps in trying to facilitate training in this area.
That's great. And Pat or Katrina, did either of you want to weigh in as well?
Yeah, I think David covered that really well.
And I think we as academics have to get out of the mindset that, you know, people going into industry is a loss. You know, it's in everybody's interest that industry has well-trained, good, competent, you know, clinical scientists involved. So
I'd also argue that it wouldn't be a bad idea if people moved into policy too, because you have a lot of influence on how, you know, like how technology could be built into mental health services at the state or county level. So don't ignore those careers either. And there'll be a lot of importance too in federal areas as well, like CMS or the FDA, where just based on some, you know, it's like, I think it's a little bit, people don't know what they're trying to support. And so if we have more people with expertise in this area, things will move a little bit more smoothly.
and just on the thing about the internship thing, I just want to give a shout out to Bethany Teachman, who's also on this call, and she's leading that. And if you're interested in it, there'll be a little bit of discussion about that at the membership meeting. So please join us there.
Okay. And we probably have time for about one or so more questions. So I see also in the Q&A a question. I really appreciate the broader systemic view being discussed here about barriers like a lack of a single payer system and lack of measurement. My concern is that the pace of new tools and developments from a design perspective will lead us building on these on a very challenging system. What are your thoughts on how we can disrupt it or push for change in the system?
Yeah, I can start by just saying that I think, yeah, maybe specifically, we have kind of pushed on those systems quite a bit at our company, and I will say it has not been for the faint of heart. We've had some wrist slaps from entrenched systems about the ways that we enroll our participants, or not participants, but our students in the system, and I think what that has looked like is a mixture of kind of policy partnership, as Pat has mentioned, and I would love to see more folks in policy kind of pushing on these things about, you know, we all claim that we want to make equitable solutions, and everybody cares about these things about equity, and that's a buzzword of the moment. But unfortunately, the systems that exist do not allow for that equity for many reasons. And so what that looks like is everything from, you know, the barriers of, you know, getting people all the way to the graduate level to provide services. Like that's a limiting factor for a lot of people, and a lot of particularly marginalized groups don't make it to that level to be able to serve their communities. And so what does that look like to have paraprofessionals who are scoped down and appropriately supervised and managed to support folks in their communities? Because we know that, you know, those people being able to help people who are closer to their lived experience, especially from the peer perspective, really matters. And then I also just think, you know, I'll give an example. We have been working with foster youth, really difficult to access group of people. And that has looked like disruption has looked like pushing on those systems and really pushing on how can we actually get services to these young kiddos and get access to, you know, push through the barriers that typically exist to get them into the system. And we have had our wrist slap, but we have partnered with some really great political folks to make sure that we can actually access those young people. So lots of interesting stories about that, but I think it is not for the faint of heart to disrupt a system.
I would echo that, like when you get into the research arena of this, and it kind of addresses a question that was in the chat that I responded to, is that when you're designing something, when you're creating a novel tool, really need to start thinking very early on in that process of where is it going to go? Like make the assumption that this is going to be effective. So how is it going to be supported? What system of care are you talking about? Who are the providers? Who are the consumers of these tools? Because the more that you can kind of consider those aspects of delivery up front, the easier it is to implement. It's not super easy. As Katrina says, I've done a lot of work with policymakers too, and it can be very challenging. But if they're involved in that conversation really early on, you'll know what the issues are. You'll be able to design around those issues and be successful.
So we're just coming up on time. So unfortunately, I'll have to cut us off there, but I want to just thank you again to each of our panelists, Pat, David, and Katrina, for sharing your insights and for all of the amazing work you've been doing to actually advance the field of digital mental health. So thank you again. And there's a 10-minute break now, and then we'll move into the Flash Talks at 3. So thanks again to everyone, and hope to see you at the Flash Talks.